Welcome to this endocrine tutorial where we will be discussing about parathyroid disease, vitamin D and osteoporosis, which would be relevant to your MRCP Part 1 exams. Now, briefly discussing about the anatomy, you all know the parathyroid are 4 in numbers, which is just situated in the neck behind the thyroid gland and principally responsible for regulating calcium and vitamin D metabolism in the body. And it is in dynamic equilibrium always with these two elements, that is calcium and vitamin D, and the response of the parathyroid gland tend to vary depending upon the levels of these two essential ingredients in the periphery. As you know that vitamin D is very important for regulation of calcium balance, and it also works closely with parathyroid hormone. Essentially produce majority of them is from the skin by the effect of sunlight. The two important steps that is relevant is the 25-hydroxylation in the liver and then the 1-alpha hydroxylation which takes place in the kidney. The active metabolite which is generated eventually is 1,25-dihydroxycholecalciferol, which has got significant effect on the bones and also promotes absorption of calcium from the intestine. And at all times this is also regulated by the serum parathyroid hormone level, and the inactive metabolite eventually, which is 24,25 dihydroxy D3, is eventually excreted by the bile. To discuss the interrelationship between calcium and parathyroid hormone, if we can focus on this graph, yes, when both the levels are normal or both is in parity with each other, it is normal. If you think that the serum calcium is high and the PTH is high, then it is primary hyperparathyroidism. If the serum calcium is low or on the normal side with elevated parathyroid hormone, which is usually secondary hyperparathyroidism. If both the parathyroid hormone and the calcium levels are low, then it is hypoparathyroidism. And at times there will be a discordant relationship between calcium and PTH, where calcium is independently elevated and it is completely PTH independent, and this tends to occur in certain circumstances like malignancy or vitamin D toxicity. The definition of primary hyperparathyroidism or the spectrum has changed over the years. Classically, we know that it is characterized by elevated level of parathyroid hormone and calcium, but now we have more commonly encountered other biochemical variants, namely a normocalcemic primary hyperpara, where the calcium levels may be normal but the PTH is high, normohormonal hyperpara, where the calcium level is high but the PTH level is still catching up and maybe either normal or on the higher side of normal, and sometimes both the elements may be normal, but there may be other indication that patient may have symptomatic hyperparathyroidism. But the key to diagnosis is essentially a non-suppressive relationship between calcium and PTH, and the degree of symptoms that patient presents with doesn't depend on the calcium level. So even if your calcium levels are modestly elevated, you can still have profound symptoms, and most of them are usually associated with low level of